Hello, everyone. It is a concerned Dr. Miskoff, and it is 9 p.m., April 22nd, 2020, here in Toms River, New Jersey, from my kitchen, vlogging on COVID-19, and wanted to start it off with wishing one of my best friends from childhood, Michael Hassenberg, a happy 50th birthday. Happy birthday, Mike, and many more. Hope you're staying safe up there in Vermont. Tonight, I'd like to touch base again on hydroxychloroquine and some recent news that's been out. There's been two studies pre-printed, one from China, one from the VA down in, I believe, South Carolina. It was the Columbia VA in conjunction with University of South Carolina and University of Virginia, did a retrospective analysis that actually suggested that mortality was higher in patients who were on hydroxychloroquine versus those who were not getting hydroxychloroquine. And that's how they looked at it. And again, it's just a retrospective analysis. It's what we call a preprint. There's more and more preprints coming out before they're peer reviewed and officially in journals, just because we're so hungry for information about COVID-19. Any information that may be helpful, again, is getting out there, at least for researchers and clinicians to look at, and the general public as well. But when they went back and looked at 368 patients that were hospitalized at that VA up until April 11th, they found that those who received hydroxychloroquine, again, had actually a higher mortality rate. It was 27.8% death rate in those receiving hydroxychloroquine versus 11.4% in those who received who did not receive hydroxychloroquine. They were receiving other standard of care, of course. And of course, everybody was receiving whatever the standard of care is right now, which is again, on a daily basis changing. Curiously, they looked at patients' hydroxychloroquine and azithromycin. So again, there were three groups: hydroxychloroquine, hydroxychloroquine plus azithromycin, and those who did not receive hydroxychloroquine. Most patients, there's been a few that I've taken care of who have received just the Z-Pak or Azithro as an outpatient coming in the door, but it's pretty uncommon to see them just receiving Azithro and not the hydroxychloroquine if they're in with COVID-19, although it has happened on rare occasion. So again, the mortality rates were 27.8% for the hydroxychloroquine group, 22.1% for the hydroxychloroquine plus azithro group, and 11.4% for those receiving no hydroxychloroquine. They looked at ventilator management, or those who went on ventilators, and in the hydroxychloroquine group, it was 13.3%. In those receiving both hydroxychloroquine or Plaquenil and azithromycin, it was actually the lowest of the three. 6.9% went on respirators. Of course, the mortality rate was fairly similar. As I said, 27.8 in the hydroxy versus 22.1 in the hydroxy-azithro combo. Those who did not receive hydroxychloroquine, just the standard of care, 14.1% of those went on ventilators. So that was actually the highest percentage group. So more patients went on ventilators by a small fraction. However, that was also the group that had the lowest mortality rate. There's been a lot of talk about, the ventilator being the death sentence. At least this study, I don't want to draw conclusions like that, but at the very least, they had a slight percentage higher ventilator use compared to hydroxychloroquine group alone, and the mortality rate was less than half, 27.8 versus 11.4. However, on the same note, the Chinese also have a preprint that came out that is somewhat positive, and this is a smaller study of just 62, but it looks to be more prospective in the sense that it was randomized for these patients to either receive hydroxychloroquine or just the standard of care. They looked at the total time to clinical recovery. They looked at fever. They looked at chest X-ray clearing or pneumonia clearing. And what was curious about this study, which I haven't seen in any other, although I haven't read every single study out there, certainly have looked at a lot of them, is this was the first one I found where there was slightly more female compared to male. It was 53.2% female, 46.8% male, essentially the same, but not that 60-40, 70-30 split we've seen in some other studies in favor of male. Again, we've theorized at least on why a female would be at less risk. Do they have a more rapid immune response sooner? Some would suggest that a more rapid immune response may be worse, or they're getting a jump on it and actually clearing it, or a better immune response, I should say. Is it that X chromosome, as we've talked about before? Is it something estrogen related? It's not clear, but certainly they do seem to be doing better overall, and less percentage being admitted. So this is the first one I've seen where a slight favor of female over male. The age mean was about 44.7 years of age. And what they found was that the group that got hydroxychloroquine had a shorter time to clinical recovery. A little sip of my Fiji water again. We haven't talked about Fiji in a while. Also, the body temperature recovery time was less. Cough remission time was significantly shortened, again, in the hydroxychloroquine group. So that was it for that. I wanted to also mention, I saw on TV Dr. Glanville out of California. We've talked about convalescent plasma. There is now, people are asking, can I get my antibodies checked? I know that New York's Department of Health has been doing clinicians. I heard that today. New Jersey, as far as I know, is not readily, at least, having healthcare providers tested yet, but I think it's very close. I know the test obviously exists. There's a finger stick, which is less accurate. Mayo Clinic's been running them for obviously the large convalescent plasma trial, and even individual hospitals are running it. But as of right now, I personally haven't been notified as a provider to be tested. The general patient population is asking, can we get tested, for antibodies? And as of right now, again, the tests exist. They're, I think, figuring out the small details and should be hopefully readily available commercially, sort of like getting your nasal swab for COVID. What about, do I have antibodies specifically for it? But that's all really great to know as far as getting people back into the population. Take some, mental worry away if you know that you've had antibodies directly, for the novel COVID virus. There's been some talk about maybe cross-reactivity of the test and what could have just been another version of corona, but I think they're working those details out now, and they pretty much have that down. But the idea is that if you test positive for those antibodies, you can then give plasma potentially. There was a requirement initially to test negative, but I think now it's just you have to be asymptomatic for a given amount of time. But this Dr. Glanville out of California has a company that is looking at using just antibodies, monoclonal created antibodies, so not human antibodies, but monoclonal, and wants to do obviously further testing, but feels that this could be definitely a game changer. However, probably would not be available till after the summer or into the fall at least. Would have to go through the appropriate clinical randomized trials, but wouldn't give you the same type of immunity as a vaccine potentially, but could be very potent and very powerful for neutralizing the COVID virus. So that would be the hope. The mechanism is disrupting that spike or S protein that we've spoken of, on the coronavirus, those different spikes that come up, and somehow disrupting that. It seems like if you can take out those spikes, you can take out the virus. You can take out the virus with hot water and soap and alcohol scrubs, etc. So I did want to mention that convalescent plasma is heating up. We know that there are donations happening in the communities, and that we have already dosed patients at our local hospitals, and there seems to be a lot more coming. So there is definitely hope for at least getting convalescent plasma. Again, all of these therapies may be helpful. Of course, the earlier we can provide them to patients, the better. We spoke on the last two vlogs about remdesivir. I really believe that will be a very positive medication and could potentially be the game changer, in fact. But we're waiting for those 6,000 patient that trial from Gilead on the severe population and 1,600 on the moderate population. Again, 94% on the pulse ox being that cutoff, as we talked about last night. But remdesivir, I think, is extremely exciting as an early treatment, and I could envision this getting early approval if that data is as good as the leak from University of Chicago, as we've talked about. If in fact we find out it's not as great, then it'll have to go through more vigorous review and potentially more studies. But I could see this all changing where in the future, hopefully by summertime or as soon as possible, remdesivir data looks great. This is very optimistic of me, but I want to stay positive, and that we get a fast approval. Maybe they could even concentrate it, highly concentrated into injectable, something that could really streamline that. Those, as soon as you get symptoms, you get tested either at home or at some sort of clinic that can run the test within hours, and you could literally be going to an infusion center, maybe an ER, maybe get admitted, or even self-inject if they could get it to that level quick enough. So that would be the hope. I think to get it to self-injectable, they'd probably need more studies through the FDA. But I could see the FDA. I mean, look what they did with hydroxychloroquine as an emergency, usage type of thing on March 28th. Who knows? So again, what's happening now is hydroxychloroquine is in debate. This is all very recent news. Up until just recently, we were pretty much putting anybody who came into the hospital on it who required supplemental oxygen, meaning that they had a pulse oximetry around 92% or less, I should say. That was a lot of the admissions, maybe up to 3/4 or more. Now we're going to second guess that because we have two conflicting preprints, one from a larger VA study retrospective, one from China, also preprint, more prospective and randomized, but small number in the 60s. But more and more reports about potential harm of mixing the two agents, hydroxychloroquine and azithro, as far as heart blocks and these types of things. So without definitive evidence, without larger trials, it may be hard to justify giving this, or at least giving it on a much more selective basis, or almost letting the patient decide and offering it. But it's a tough call until we have more of this information out and published. We are still using anti-interleukin 6 blockers, both tocilizumab and sarilumab in a clinical trial with an 80-20 randomization. 80% get the drug, 20% don't, giving that to patients admitted on the floors, not necessarily ICU or pre-ICU. If they are requiring supplemental oxygen, if it's minimal oxygen, we may watch them. Otherwise, it's being offered, and it's up to the patient. Usually getting that one-time infusion, but now I'm hearing they may be getting repeat infusions or tocilizumab. Usually those were patients that had hit the ICU, ended up on respirators, and were hit pretty quick with Actemra, tocilizumab, and then maybe a second dose, although we're starting to wonder if that immunosuppresses them. If you give them more than one dose, and are we seeing more potential infections is not determined yet, but keeping an eye on that. Convalescent plasma, as I mentioned, and other than that, some supplements, and these patients are staying vented for many days, and definitely it's challenging to see them, and they are being proned, and it does help with oxygenation, but we do not have any silver bullet today, but extremely excited to hear the Gilead data on remdesivir to come soon. Hopefully we have that in the next couple weeks. Everybody, please stay healthy, stay well. Michael, happy 50th again to you, and we'll see you again.